Well, when I was training in cardiology, all the focus was on the myocardium, but we now recognize that the myocardium is really just the innocent bystander in most important cardiovascular diseases. Hypertension and atherosclerosis are diseases of the blood vessel. Atherosclerosis has a relationship with risk factors, most notably low-density lipoprotein, depicted in those yellow balls, but there are many other non-traditional risk factors which we're learning about. But let's consider LDL, because that's something which we think we understand better than the others. LDL, when it accumulates in the intima, can become modified, as shown by this brown color. Dr. Whitston will speak about that tomorrow. And that can instigate an inflammatory response, which causes the expression of adhesion molecules on the endothelial cells, which will engage cognate ligands on the leukocytes. There will then be diapedesis of the adherent leukocytes into the intima. Scavenger receptors will be expressed, as we saw. That will permit transformation of these cells into foam cells, the hallmark of the intimal xanthoma, if you will, which usually moves outward, remodeling. We have formation of the fibrous cap begins when the smooth muscle cells replicate and begin to secrete the matrix constituents that we heard about. Other smooth muscle cells will migrate in from the media into the intima. And this is how we have evolution from that intimal xanthoma to the fibrous cap kind of lesion, the fibrofatty lesion. And when we have persistence of the risk factors, such as high LDL, over a prolonged period of time, we allow growth of that lipid core, usually in an outward direction for the first part of the history of the plaque. And we have an inflammatory response where the T cell can send soluble signals to the macrophage or activate the macrophage, as Dr. Schoenbeck and Mach have shown, by contact through CD40 ligation. The activated macrophage can secrete a myriad of mediators, including the matrix metalloproteinases, which can weaken the collagen in the plaque's fibrous cap, rendering that fibrous cap thin, friable, and susceptible to rupture. And when one has rupture and a sustained and occlusive thrombus, that can cause acute myocardial infarction, as depicted by the ST segment elevation. But as we've heard before, plaque rupture is a banal event and is usually subclinical. Sometimes a non-sustained or subtotally occlusive thrombus can cause an episode of unstable angina. But when we have healing due to the TGF-beta and PDGF, we have increase in collagen synthesis, and that thickens the fibrous cap, but we have a narrow lumen, and this is how we get to that stable kind of thick fibrous cap lesion. May cause symptoms, but is less likely to cause thrombosis. And when we intervene, when we try to modify this process with lipid lowering, we allow, as shown by our rabbit experiments, decrease in the inflammatory cells and the lipid. Here's some apoptosis going on, shown by the Tinkerbell phenomenon. We have a thickening of the fibrous cap, maintenance of the lumen, and that is how I believe that we're successfully modifying coronary disease with lipid-lowering therapy as we stand here on the threshold of a new millennium. Thank you very much.